Welcome to this Smith+Nephew digital education module on time. This forms part of a series of modules you can access to develop your knowledge and understanding around wound care. My name is Gemma and I am one of the wound care specialists at Smith+Nephew, and today we will be discussing wound bed preparation, with the main focus being on the edge of wound. This presentation describes the challenge, intervention and anticipated outcomes, and by the end of the module you will be able to discuss what a healthy wound edge should look like, understand the importance of non-advancing edges in wound healing, the different interventions clinicians can make to manage wound edges, and discuss the importance of reassessing and re-evaluating care. Epithelial edge advancement and an improved state of surrounding skin is the clearest sign to healing, and a 20 to 40% reduction in wound area after 2 to 4 weeks of treatment is seen as a reliable predictive indicator of healing. If the wound is not reducing in size after 2 to 4 weeks, we should investigate and correct the problem. And this would involve a full holistic assessment of the patient to identify factors that could be delaying wound healing. E represents edge of wound, non-advancing or undermined. This is the final component of time, and it is the active division, migration and maturation of epidermal cells from the wound margin across the open wound. When we talk about non-advancing, this means that the wound is not making any progress, and undermining means that the wound bed is not attached to the wound edge, which is going to prevent the wound from making progress unless appropriately managed. The aim of any treatment should be to promote epithelialization and healthy peri-wound skin, which can be carried out in a number of ways depending on your local policy within the area that you work. For instance, when using negative pressure wound therapy, it is important to protect the peri-wound skin and the wound margins to prevent overgranulation. So what should we expect to see in a healthy wound for wound edges to be able to migrate across the wound? The wound bed must be full of well vascularized granulation tissue in order for the proliferating epidermal cells to migrate. It's important to ensure the wound bed is always well prepared. Always consider the elements of T, I and M first to ensure that the wound is able to epithelialize. Assessment of wound edges can indicate whether wound contraction and epithelialization is progressing, and confirm either the effectiveness of the wound treatment being used or the need for re-evaluation. A healthy wound bed and peri-wound are important to support progress. In a healing wound, the wound edges include a thin, pale pink to translucent wound margin, as seen here. The non-healing wound edge will be very different to this, which we will go on to. Epithelialization needs cell migration over the wound bed so that it can then attach to the edge of the wound. So, as already mentioned, the wound must be well vascularized with granulation tissue, and it's important to regularly assess the wounds according to local policy, as the wound state can change and management interventions will also need to be considered. Factors contributing to a non-advancing wound edge are the same as those which cause delayed wound healing in general and ultimately keep the wound in an inflammatory state. High levels of matrix metalloproteinases, MMPs, may prevent cells at the wound edge from responding to healing signals in the wound. Therefore, it is important to address T, I and M of time. A desiccated or macerated wound edge can also affect the progress, and the wound will not go on to contract, and this requires management interventions. A non-advancing wound edge may appear as epibole, as seen in the picture. This is a term used to describe wound edges that have rolled inward on themselves. Causes of epibole can sometimes be associated with wrongly dressed wounds. By appropriately filling in those dead spaces with the use of wound fillers or other appropriate products of choice, the wound edges will then migrate and contract without complications such as epibole and undermining. Other examples of non-advancing wound edges include hyperkeratosis, which is a build-up of keratinocytes at the wound edge, a callus, which commonly occurs around neuropathic diabetic foot ulcers, which can be seen in the top right photo, or unattached or undermined, in which the edge of the wound is not connected to the wound bed, and that can be seen in the bottom right photo. The intervention goal for the non-advancing wound edge is to re-establish an open wound edge from which epithelial migration can occur. Diabetic foot ulcers, for example, often require sharp debridement of the wound and the surrounding callus. This is usually conducted by creating a saucer-shaped wound, giving the epidermal cells an easy path for migration. However, this is usually carried out by a skilled and competent practitioner. The clinician should also consider the condition of the peri-wound skin in assessing wound contraction. Dry or macerated wound edges may affect the ability for the wound to be able to contract. For undermined wounds, interventions to promote a moist healing environment may allow the wound edge to reattach to the wound bed. Examples of other interventions include negative pressure wound therapy, the use of growth factors and/or skin substitutes in the form of prescribed creams or emollients. After working through the treatment decision tool using time principles, the last step is to evaluate progress and assess the patient's wound's response to treatment. Has the wound progressed? Examples of progression may include removal of non-viable tissue, evidence of decreased bacterial burden, or a decrease in wound depth or surface area. The European Wound Management Association suggested that a useful general measure of healing outcomes in different wound types is through the recognition of reduction in wound size by measuring the advancement of the wound edge. Inappropriate, inaccurate, or lack of wound assessment can lead to delayed wound healing, pain, increased risk of infection, inappropriate use of dressings, and a reduction in quality of life for patients. Therefore, if a wound is not progressing, a full holistic assessment should be repeated. To check your knowledge and understanding, try and answer the quiz questions. You have now completed this module. Take the time to reflect on how you will take some of what you have learnt today and apply it to daily practice. If you are on the NMC register, then please click on the link shown to access a copy of the revalidation form. Simply put the title of the session on the form and file in your portfolio. Thank you for your time today. Please remember to look at the other sections to access other modules to help you on your learning journey.